Hello and welcome to the webinar, Uterine Endometrial Cancer 201, What You Need to Know. I'm Nefertari Moore, Outreach and Uterine Program Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women cancers and provides outreach to the general public about signs and symptoms, because no one should face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation when Dr. Wright and Jacqueline and Bio finish presenting. We will begin the Q&A discussion. You are welcome to submit your questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. Wright and Jacqueline are unable to give specific advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. And now I'd like to introduce our first speaker. Dr. Wright is the Stowe Goldman Associate Professor, Chief of the Division of Gynecologic Oncology, and Vice Chair of Academic Affairs in the Department of Obstetrics and Gynecology at Columbia University College of Physicians and Surgeons and the York-Presbyterian Hospital. Dr. Wright received his medical degree from the University of Missouri and completed his postgraduate training at Washington University Barnes-Jewish Hospital in St. Louis. Dr. Wright's primary area of research focus is comparative effectiveness and outcomes. Research in his work has examined the use of novel drugs and technology for cancer patients, surgical quality, fertility preservation in cancer patients, and the management of complications in cancer patients. He has published more than 500 scientific manuscripts, as well as numerous chapters and textbooks. Dr. Wright is the editor-in-chief of Obstetrics and Gynecology and lectures nationally and internationally. And now I'd like to turn it over to Dr. Wright.
Thank you so much, Nefertari, for the introduction. I'm going to share my screen. So good afternoon to everybody who's on the webinar today. It's a real pleasure for me to be here today. I want to thank SHARE for sponsoring this webinar and putting this together among the many activities they do to support gynecologic cancer and patients with gynecologic cancer. So as Nefertari said, the title of my talk today is Uterine and Endometrial Cancer 201, What You Need to Do. This is a follow-up on a presentation I gave now about 2 years ago, also to the SHARE group. And what I hope to do today is really talk through endometrial cancer and talk about some of the basic, our basic understanding of endometrial cancer, how it develops. I want to spend some time talking about the diagnosis and the symptoms that women should be aware of that are possible signs of endometrial cancer. And then I'll spend the remainder of the talk talking about the treatment of endometrial cancer and uterine cancer, specifically the initial therapy of the cancer and adjuvant therapy. And then I'll end the presentation and talk about some of the newer treatments that are available. And again, I think for uterine cancer, the last 5 years has really been seen a sea change in the number of potentially active treatments that we have for women with uterine cancer. So something I think really exciting to see the advances in the new drugs that have been developed that are active for this type of cancer. So just a little in the way of background before we get started. This is a cartoon of the pelvic anatomy, specifically showing the uterus. So the uterus is what women refer to as the womb often, and the uterus is really made up of a number of different parts. The lining of the uterus uterus is called the endometrium, and the center part, or the muscular part of the uterus, is called the myometrium. So endometrial cancers are specifically cancers that arise along the endometrial lining, and uterine cancers are cancers that really can occur in any part of the uterus. So these terms, while they are a little bit different, they're often used interchangeably when we're talking about these types of cancers. This is a picture. This is a slide of a patient who's undergone a hysterectomy for a uterine cancer. You can see the uterus on the slide on the left-hand side of this screen is the uterus that's been opened up. And the majority of uterine cancers start out on the lining of the uterus, the endometrium, and are endometrial cancers. And you can see the cancer here kind of along the inner lining of the uterus, kind of just to the left of where the arrow is pointing on the left-hand side of the screen. Now, what we know about endometrial and uterine cancer is, unfortunately, it is a very common cancer among women. On the left-hand side of the screen, you can see the incidence rates for the different cancers that occur in women. And you can see that uterine cancer is actually the fourth most common cancer in women, with just over 66,000 cases each year. And I think, most people, when you ask them, most people are not really aware of uterine cancer, but you can see by these statistics that the annual incidence of uterine cancer is fairly close to the annual incidence of colon and rectal cancer in women. So this is an extremely common cancer that we see in women. Uterine cancer is the sixth most common cause of cancer-related mortality in women. You can see the statistics here. So fortunately, it's much less common to have a mortality from uterine cancer than it is than the actual incidence of uterine cancer. And that's due predominantly to the fact that many uterine cancers are detected very early, and they're highly curable with the treatments that we have. Now, I think some disturbing trends that we see when we look at uterine cancer. The first of which is that the rate of uterine cancer is increasing fairly dramatically in the United States. So this is a study from the American Cancer Society that shows that each year the number of women who are being diagnosed with uterine cancer is increasing by about 1.3%. But I think even more alarming, what we're seeing is that there are an even greater number of deaths each year that are occurring from uterine cancer. So year over year, each year, there are 2% more women who are dying from uterine cancer than the year before. And again, this is, when you look at these statistics, this is fairly alarming, because the increasing death rate that we see from uterine cancer is greater than any of the other human cancers. So I think, again, something definitely alarming, that we are seeing rapid rises in both the incidence and the mortality of uterine cancer. I think that the second really sobering fact when we think about the statistics around uterine cancer are really the profound racial disparities that we see for uterine cancer. This is a graph looking at the incidence of uterine cancer stratified by race from 1999 to 2015. And you can see while the incidence of uterine cancer is increasing overall year over year, we see a much greater rise in uterine cancer among Black women compared to white women. And you can see the statistics here. There's been a 46% increase in uterine cancer in Black women compared to a 9% increase in white women. And now the annual incidence, the annual cases of uterine cancer are nearly identical between Black and white women in the United States. We also, as I showed you before, we also see, as we see a rising mortality from uterine cancer, and we also see widening racial disparities in the death rate from uterine cancer. You can see that on this slide, where Black women are nearly twice as likely to die from uterine cancer as are white women. And these trends and this disparity in survival is increasing year over year. So I think really, worrisome trends overall in the incidence rates for uterine cancer, but also I think really disturbing trends in the racial disparities that we see in the incidence of this disease. Now, when you look at uterine cancer, this is a schematic kind of looking at the development of uterine or specifically endometrial cancer. On the left-hand side of the screen, you have the normal lining of the uterus, the endometrium. And what can happen is the endometrium can develop precancerous changes. And that precancerous condition is called endometrial hyperplasia. And if that endometrial hyperplasia is not caught or detected or treated, it could ultimately, over the course of months to sometimes years, can ultimately progress and turn into a uterine cancer, which is the picture on the right-hand side of the screen. Now, there are a number of factors that drive this progression of the uterus from normal endometrial tissue through the precancerous change all the way up to cancer. So really any type of estrogen that can stimulate the uterus and promote this sequence. So the most common cause that we see of estrogen is obesity. So obese tissue, adipose or fatty tissue in the body produces estrogen. And this estrogen that's produced by the fatty tissue can lead to stimulation of the endometrium and lead ultimately to the development of cancer. And the increasing rate of obesity in the United States is probably one of the driving factors why we're seeing an increase in the incidence of uterine cancer. There are a number of other factors, hormonal factors, things like being on tamoxifen that can promote endometrial cancer, and then reproductive factors. So, never having delivered a baby, early onset of periods, late onset of menopause. All of these are factors that can promote the incidence of uterine cancer. And then there's a subset of uterine cancers, probably around 10% of uterine cancers that are hereditary and caused by what's called Lynch syndrome. And I'll show you some of the statistics on Lynch syndrome in a couple of slides. So I said, probably for women, the most important and the most common risk factors for endometrial cancer are number one, aging. So the older women are, the increased risk of uterine cancer. The average age for uterine cancer is in the early 60s in the United States. And number two, obesity is probably the strongest risk factor overall for endometrial cancer. And you can see some of the statistics here. For every 5-unit increase in the body mass index, which is basically your weight divided by your height, it results in a 50% increase in the incidence of endometrial cancer. So really a quite dramatic association between obesity and the risk of endometrial cancer. I think what's also concerning is not only does obesity influence the actual incidence of endometrial cancer, but obesity is associated with outcomes. So obese women with uterine cancer have a decreased survival and an increased mortality compared to women who are leaner with uterine cancer. That's probably due to a variety of factors, tolerance to treatment, the ability to offer various treatments. So obesity, very important factor both in the initial development as well as the treatment of endometrial cancer. Now, as I mentioned, there are a subset of endometrial cancers that are hereditary. And what that means is that you're predisposed because of a genetic predisposition to endometrial cancer. So some type of gene that you've inherited from either your mother or your father. And the most common hereditary syndrome associated with endometrial cancer is what's called Lynch syndrome, or what was formerly called hereditary non-polyposis colorectal cancer syndrome. So this is a hereditary syndrome that you can inherit from your parents. And it's the defect of one of these 4 genes that causes that helps to repair the DNA in the body's cells. So if you have an abnormality of these genes, basically the body can't repair DNA and it predisposes you to the development of cancer. Now, what we know about Lynch syndrome is extremely common. So when you look at just, everyone in the United States, both males and females, 1 in 300 individuals are carriers for Lynch syndrome. So 1 in 300 people in the US possess this abnormality that predisposes them to cancer, including endometrial cancer. And we know that particularly in young women who develop endometrial cancer, there's a relatively high rate of Lynch syndrome in these young women. You can see from this slide that the risks associated with Lynch syndrome. So the 2 most common cancers for Lynch syndrome are endometrial cancer and colon cancer. So the lifetime risk up to age 70 to 75 for patients with Lynch syndrome is about 80% to develop colon cancer and up to 50% to develop endometrial cancer. There are a number of other cancer types that are listed here that are also associated with Lynch syndrome, in addition to endometrial cancer and colon cancer. Now, fortunately, we do have some screening tests for patients who are diagnosed with Lynch syndrome. So for colon cancer, it's recommended that women undergo a colonoscopy. that can begin at age 20 and should occur annually after age 35 for the detection of endometrial cancer and for ovarian cancer. It's recommended that women undergo ultrasound, CA-125, and pelvic examinations annually starting at age 30 to 35. And for those women who've completed childbearing, there's also the possibility of risk-reducing surgery, so removal of the uterus and the ovaries to try to decrease the risk of both uterine cancer as well as endometrial cancer. So what do we know about the diagnosis of endometrial cancer? Again, I showed you at one of the early slides that fortunately the incidence rate is much higher than the mortality rate from endometrial cancer. And what that means is that a relatively large number of women who are diagnosed with endometrial cancer can be effectively treated and they can be cured of their cancer. And really the primary reason that the outcome is favorable overall for endometrial cancer is because many women are diagnosed very early with an early stage cancer. And that's due in large part because of the fact that these cancers are often associated very early on in the process with signs and symptoms. And by far and away, the most common symptom of endometrial cancer is vaginal bleeding. So abnormal vaginal bleeding, particularly for women who have gone through menopause, so we're postmenopausal women who develop bleeding, that's often a sign, an early sign of endometrial cancer. Now, what we know is that the vast majority of women with postmenopausal bleeding, 9 out of 10 women do not have endometrial cancer, but about 10% of postmenopausal women with bleeding will ultimately be found to have endometrial cancer. So it's really, imperative, if there's one, take-home point today, it's that if a postmenopausal woman experiences bleeding, that she tells her doctor, she gets into her doctor, and she gets evaluated for the abnormal bleeding. There are other signs and symptoms associated with endometrial cancer. They tend to occur less commonly than bleeding, but you can see those listed here. So abnormal vaginal discharge, pelvic pain and pressure, an enlarging uterus that your doctor may detect on examination, or for younger women, abnormal bleeding, either heavier than expected periods or bleeding between your period, what's called intermenstrual bleeding. So again, these are a little bit less specific, but also signs and symptoms for endometrial cancer that women should be aware of and on the lookout for. Now, there are, in addition to the presence of symptoms early on, there are a number of very accurate diagnostic tests for uterine cancer. So typically, if you are evaluated by your doctor, it'll start out with your doctor talking with you, going over and doing a history and a physical examination. The doctor will also often do a pelvic examination to feel the uterus and a pap smear. And then the two tests we'll often use specifically for endometrial cancer are, number one, transvaginal ultrasound. So taking an ultrasound and looking at the uterus, looking for abnormalities, specifically looking at the thickness of the lining of the uterus, and then doing a direct biopsy, either in the office or in the operating room, where your doctor will insert a small instrument into the uterus and take a sample of the lining of the uterus. So it's a test that's highly accurate, highly sensitive for the diagnosis, particularly of endometrial cancer. So that the combination of symptoms that develop early, as well as the availability of relatively non-invasive diagnostic testing, again, have helped make the overall the prognosis for uterine cancer relatively favorable compared to some other types of cancer. So there are a number of different types of uterine cancer that can develop in women, and you can see the traditional classification schema here. By far and away, the most common types of cancers are what we call type 1 endometrial cancer. And you can see the different types of type 1 endometrial cancer here. These are cancers that tend to be driven by estrogen, so particularly obesity or hormonal factors that cause stimulation of the endometrium. And this group of tumors tend to be the cancers that are detected early. These tend to be the cancers that are associated with a very favorable prognosis, and these are cancers that are highly curable. The more aggressive types of cancers are called what are called type 2 endometrial cancers. And you can see the different type 2 endometrial cancers here: clear cell carcinomas, uterine serous carcinomas, carcinosarcomas. These tend to fortunately be the minority of endometrial cancers. Probably around 15 to 20% of endometrial cancers are type 2 cancers, but these tend to be very aggressive cancers that, number one, are more likely to spread beyond the uterus at the time of diagnosis, and number two, for women who do have these types of cancers, these cancers are more likely to recur after treatment. So we typically treat these cancers more aggressively with some additional therapies as opposed to type 1 cancers, which are sometimes treated a little bit less intensely. Now, we fortunately know a lot about the way that uterine cancer develops and spreads. As I said, what typically happens in most women is uterine cancer develops along the endometrium, the lining of the uterus. And very often the cancer is detected while it's still confined to the endometrium. But if it's not detected, what happens is the cancer can start to spread. And the first way it spreads is it starts to grow into the wall of the uterus. So you can see that on the middle panel of this figure, what's called a stage 1B endometrial cancer, where the cancer started on the lining of the uterus, and now it's started to spread and grow into the wall of the uterus. If the cancer is not detected, eventually it spreads outside of the uterus. And the first place it spreads are to the lymph nodes, which are the little areas that drain the uterus. You can see in the little schematic, the lymph nodes that are kind of all around the uterus. So really, when we think about treatment, what we think about is number one, taking out the uterus, and then number two, doing evaluation to make sure that the cancer has not spread to these lymph nodes within the abdomen and within the pelvis. So primary treatment for the vast majority of women with uterine cancer, primary treatment typically starts out with surgery. And the goal of surgery is twofold. Number one, it's to get the cancer removed, so a hysterectomy, typically in combination with oophorectomy or removal of the ovaries. And then the second major goal of surgery is to determine how far or if the cancer has spread. And the way that we do that is to do a lymph node evaluation, either what's called a lymphadenectomy or a lymph node sampling. I think over the last 2 decades, one of the great advances in the way that we're able to treat endometrial cancer has been the result of improved surgery. And that, again, as I said, that typically starts out with hysterectomy. Now, what typically happens if you were treated with uterine cancer 20 years ago, what typically happens is you would come in and your doctor would make a large incision, either up and down or in the bikini line, the little blue lines on the right-hand panel in the screen. So this big incision was associated with a big surgical procedure. Women would typically be in the hospital 2, 3, 4 days after the procedure, and the recovery after surgery would be about 6 weeks after the procedure. Fortunately, now we have less invasive surgical techniques for the treatment of uterine cancer. And what those are is a procedure called a minimally invasive surgery or laparoscopy. And you can see that the goal of laparoscopy, instead of making one big incision, we make multiple small incisions on the abdomen represented by these green dots on the slide. And instead of the big incision, we introduce small instruments through these green dots. And the recovery time is typically much better for women who undergo minimally invasive surgery. So instead of being in the hospital 2 to 4 days, sometimes women can even go home on the day of surgery after a minimally invasive hysterectomy. And importantly, there's now very good data that minimally invasive hysterectomy is safe for the management of endometrial cancer. We obviously don't want to do a procedure that's less safe, less likely to cure the cancer by doing this less invasive procedure. So this is one study. This is a study that was done in Europe that looked at over 750 women, and the women were randomized either to traditional surgery or minimally invasive surgery. And what you can see from these figures is that the survival, the chance of curing the cancer, was essentially the same between the two types of surgical procedures. For many women with uterine cancer who undergo minimally invasive surgery, many women will undergo laparoscopy, but many women will also undergo a type of procedure called robotic surgery, where essentially, again, you have the small incisions of laparoscopy, but there's a surgical robot that essentially helps your surgeon manipulate the instrumentation at the time of the operation. Now, the second component of surgery, in addition to removal of the uterus, is to do a sampling of the lymph nodes to make sure that there's no cancer that's spread to the lymph nodes. And again, particularly over the last decade, we've seen great advances in the way that we're able to sample these lymph nodes. So 10 years ago, traditionally what we would do is we would go in and we'd remove all of the lymph nodes in the pelvis. And this is a long procedure. It can be associated with postoperative complications, swelling in the lower extremities. The technology is now much better on the way that we can sample these lymph nodes. And we often do a procedure that's called a sentinel lymph node biopsy, where instead of removing all of the lymph nodes down in the pelvis, we just take the lymph nodes that are most likely, to be affected by cancer, what's called the sentinel lymph node. And we now know from research studies that this procedure, the sentinel lymph node biopsy, is essentially equivalent in the ability to detect lymph node metastases as the traditional lymph node sampling or lymphadenectomy. So this is now a common part of surgery as well for women who are newly diagnosed with endometrial cancer. Now, like anything in medicine, there are a number of different caveats and considerations for people who are diagnosed with uterine cancer. Number one, as I told you, endometrial cancer typically occurs in older postmenopausal women, but we are seeing more younger women who are now diagnosed with endometrial cancer. And there are a number of potential treatment options for younger women. Sometimes we can do medical management where we're able to preserve the uterus. And sometimes we also are able to preserve the ovaries in women who do undergo hysterectomy. So again, these tend to be very specific circumstances. Women should talk to their doctor about these treatment options, but these are both considerations in women who are less than 50 years of age. And at the other end of the spectrum, there are some women who either have advanced cancer, who have underlying medical problems that make surgery unsafe. And these women sometimes will do alternative treatments, sometimes a different route of hysterectomy, sometimes we'll do radiation, sometimes now we'll even do chemotherapy before surgery in women with endometrial cancer that's spread beyond the uterus. So again, the treatment it often starts with surgery for endometrial cancer, but there are also a number of new treatments. So this is highly individualized and warrants a good discussion with your doctor. Now, after surgery, what we typically do is we take all of the factors, we assess how much cancer, the type of cancer that's in the uterus, if the cancer has spread, and based on those factors, we make a decision on what the risk that the cancer will come back is. So for women who have very early tumors, what are called low-risk cancers, where the risk of the cancer coming back is very small, often the only treatment that we need to do is to do the surgery that I just described. For those patients who have more advanced cancer, either growing into the wall of the uterus, spread beyond the uterus, then sometimes we need to do some additional treatment. And that additional treatment may either be radiation, sometimes chemotherapy, sometimes a combination of both chemotherapy and radiation therapy. So probably overall, the most common treatment after surgery for women with endometrial cancer is radiation therapy. So there are a number of different ways to deliver radiation therapy. On the left-hand side of the screen is the traditional type of radiation that's called external beam radiation, where you come in and a device delivers radiation beams every day to the area where the uterus used to be. But often now we're doing a less invasive form of radiation, a type of radiation that's called vaginal brachytherapy or intercavitary radiation. And essentially the way this radiation works is we put a small device in the vagina, deliver a dose of radiation, and then remove that device from the vagina. And we'll typically do 3 to 5 treatments. The treatments tend to be fairly quick and they tend to be less invasive than the traditional whole pelvic radiation. So there are now some studies that for some patients, these two forms of radiation are associated with similar chance of curing the cancer and curing survival. So for many women now, we're able to do this vaginal brachytherapy as opposed to the more traditional whole pelvic radiation treatment. I think the other major advance in addition to surgery over the last 2 decades is really a better understanding of the way that uterine cancer behaves. And what that's led to is it's led to a better understanding of how we can effectively use chemotherapy to treat uterine cancer. So prior to 2000s, the chemotherapy was really, used very little. It was uncommon for the treatment of endometrial cancer. Now chemotherapy and effective chemotherapies are used much more commonly. So in addition to the radiation modalities that I just told you about, for those women with cancers after surgery, which are at higher risk for coming back and recurring, we'll often administer chemotherapy either alone or in combination with radiation treatment to try to reduce the risk of cancer relapse. So again, the chemotherapy, nowadays, I think most of them, often come in and they have horror stories of chemotherapy. Chemotherapy that we use now is much more tolerable than it was 20 years ago, number one. And number two, we now often we have better medications to help manage some of the side effects that are associated with chemotherapy. So now for women who have to undergo chemotherapy, chemotherapy is often much better tolerated than it was in the past. So again, this is becoming an increasingly common form of treatment after surgery in women with endometrial cancer. Now I want to spend kind of the next 10 minutes or so of the talk, speaking about some of the novel therapies and the novel therapeutics that we have for endometrial cancer. So, I used to, give talks on endometrial cancer, even 5, 6, 7 years ago. When I talked about recurrent endometrial cancer, I used to, make the comment that there really hasn't been a new drug that's been approved for this cancer in over a decade. So research was really stalled. We didn't have new treatment options. We didn't have good treatment options for endometrial cancer when it comes back. Over the last 5 years, there's been a dramatic shift in the way that we understand, number one, and number two, the way that we think about recurrent endometrial cancer. And now there are a number of very, very effective drugs for recurrent endometrial cancer, and there are a number of new drugs that are emerging every day for women with recurrent endometrial cancer. So again, that's I think, for those women whose cancer does come back, there now is, hope, and there are lots of drugs that are available and lots of different ways to give these drugs in different combinations or in different sequences that I think it has really been one of the most exciting things overall in the treatment of endometrial cancer. Again, in particular, much of this is just over the last 5 years. So, all of these changes and new drug availability has really been the result of us having a better understanding of endometrial cancer. So I think kind of the historical understanding of endometrial cancer is a slide that I showed you before, where we look under the microscope, we look at how the endometrial cancer looks, and we kind of classify the endometrial cancer into two big buckets, either as a type 1 or a type 2 cancer. Really, the way that we're approaching endometrial cancer now is dramatically different. So instead of just looking under the microscope at cancer, what we're doing now is we're actually analyzing the genetics, the DNA within an individual patient's cancer to have a better understanding of the individual type of cancer that this is, and potentially identify drugs that the cancer may respond to. This is what people often talk about as precision medicine or personalized medicine. Instead of kind of one size fits all for endometrial cancer, now what we're able to do is we're able to take the individual cancer, we're able to study and understand the DNA and the genetic and the molecular changes within a cancer, to use that information to help us better predict the way that a cancer will behave. And then second, to be able to design more active and effective therapies based on the specific genetic abnormalities within a given cancer type. So this is data from a large project in the United States called the Cancer Genome Atlas, or the TCGA Atlas. And basically what this study did is it took a large number of women with uterine cancers. It took those uterine cancers and it looked at the specific molecular changes within the uterine cancer. And based on the molecular changes, the study was able to come up with a number of different categories of endometrial cancer. And you can see those 4 different categories here. Some of these are common, like the middle ones, that are called the low CCN variants, or the MSI, MMR deficient endometrial cancers. And some of these are more rare subtypes, the TP53 serous-like carcinomas and the POLE ultramutated carcinomas. But each one of these subtypes has a very specific molecular signature, and we can use our understanding of that molecular signature to really target specific drugs and specific therapies based on the patterns that you see here. And you can see different survival rates. The top line, the TP53 serous-like tumors, tend to be rare, but they tend to be very, very aggressive tumors that are much harder to treat. The third line down, the MSI, MMR deficient, I'll show you now we have very specific drugs drugs that basically use the body's own immune system to target these types of cancers in a very effective manner. So we use this information to classify tumors. We can use this to counsel on the risk that the cancer will come back. But then if cancer does come back, we can use this information to develop targeted therapeutic approaches for women with endometrial cancer. I'm going to talk about kind of three large classes of what I call emerging therapeutics for endometrial cancer that your doctor may talk about. And again, these are all different ways to attack a cancer as opposed to traditional chemotherapy, which is basically just a non-specific approach to targeting cancer. So the first is anti-angiogenesis therapy. So what anti-angiogenesis therapy is it's basically blocking the blood supply that goes to a tumor. We know that for any tissue in the body, including any cancer, to grow, the cancer has to have a blood supply. And there are now drugs available that can basically target this blood supply. And it could kind of prune off or cause regression of the blood vessels that actually go into a cancer. Now, the most common anti-angiogenesis drug is a drug called Bevacizumab or Avastin. So this is a drug that's commonly used for a number of different cancers, including ovarian cancer, colon cancer. But this drug has now been tested in endometrial cancer. And there are a number of different studies looking at Bevacizumab for endometrial cancer. This is just one of the studies that you can see that women who received chemotherapy, the carboplatin and paclitaxel, those women who received the chemotherapy in combination with Bevacizumab, the survival was on average 10 months longer than those women who just received chemotherapy alone. So a very strong suggestion that adding this type of therapy to traditional chemotherapy may enhance the way chemotherapy works, and it may attack cancers in a different way and improve outcomes for women with recurrent endometrial cancer. Second broad class of chemotherapeutic agents, targeted therapeutic agents that I'll talk about are specifically agents that target specific molecular pathways in the cell. So again, this is using that genetic data that I talked about to identify specific abnormalities in an individual patient's cancer, and then design drug therapies that can specifically target that abnormality. And now for uterine cancer, there are really a couple of really highly successful treatments that we have. The first drug that I'll talk about is a drug that's called Trastuzumab. People know this as Herceptin, which is a drug that's commonly used in breast cancer. We now realize that a specific type of uterine cancer, it's called a serous carcinoma, which is one of those aggressive type 2 TP53 cancers, very highly aggressive type of uterine cancer. We now know that about a third of serous carcinomas have a very specific molecular abnormality called expression of HER2/neu. And why this is important is this drug Trastuzumab, Herceptin, targets these abnormalities in the HER2/neu pathway. So this is a study looking at patients with these very aggressive advanced stage serous carcinomas, and women were either treated with chemotherapy alone or chemotherapy with Trastuzumab. And what you saw is that women who received the Trastuzumab did much better than those women who did not receive the Trastuzumab, who just received the chemotherapy. Particularly, this drug appears to be particularly effective in patients who've undergone surgery, all the cancers removed, and who are going to receive adjuvant chemotherapy if we give this Trastuzumab along with the adjuvant chemotherapy right after surgery. It's been shown to really dramatically improve outcomes. So now we're using this information, we're testing everyone with these serous carcinomas for this specific molecular abnormality. And if women do have this abnormality, we're often giving this drug Trastuzumab in combination with chemotherapy. Really, the second example of targeted therapy is a pathway called the Pi3 Kinase Akt Pathway. So this is, again, a very specific molecular pathway, tends to be abnormal in a fairly significant number of women with endometrial cancer. And again, this is important because now we have drugs that specifically target this pathway. So these are our drugs of everolimus, letrozole. Very infrequently were these drugs utilized in uterine cancer until we understood the biology and the molecular genetics of uterine cancer. And we found out that this pathway is often abnormal in women with endometrial cancer. So now we can take women who have this, potentially have abnormalities in this pathway, and we can use combinations of these drugs to try to specifically target the cancer. Letrozole is a very common drug, again, used for breast cancer. Everolimus is an intravenous drug that's used for a number of other cancers. But again, until we understood the biology of endometrial cancer, we almost never used these types of drugs for endometrial cancer. And the last novel therapeutic I'll talk about for endometrial cancer is immunotherapy. So the combination of the concept of immunotherapy is basically, instead of giving drugs that directly attack the cancer, either traditional chemotherapy or targeted therapy, what we do is we give a drug that basically tricks the body's immune system. And it basically allows the body's immune system to be upregulated, so your body's own immune system can attack and kill cancer cells, can kill the endometrial cancer cells. Now, this is a type of therapy that's extremely effective for endometrial cancer. So this is a study from 5 years ago. This is really, a sentinel study that basically looked at the specific biology of a number of different cancers. You can see those cancers here on this slide. Over 12,000 cancers were analyzed for what's called DNA mismatch repair. And what we know is if a cancer has DNA mismatch repair, that cancer is much, much, much more likely to be responsive to immunotherapy. And I think what you can see here in the really, really profound revelation that this study found is that of all of the human cancers, endometrial cancer was twice as likely as the nearest other nearest cancer to possess one of these mismatch repair deficiencies. So again, really suggesting that this could really be highly effective for women with endometrial cancer. And this may be a very relevant target for women with endometrial cancer. Now, this concept has been tested. There have now been drugs that have been approved by the FDA for treatment of endometrial cancer. The first one of those drugs is a drug called Pembrolizumab, or the trade name for this is Keytruda. You've probably seen commercials for this. This is used for a number of different cancers. But when we gave this to women with endometrial cancer who had this specific profile, this DNA mismatch repair profile, what we found is really dramatic results. So the response rate to this drug was nearly 50%, which is probably, in women with this combination of characteristics, probably twice what you would expect for chemotherapy. But I think the really remarkable thing is we found not only did women often respond well to this drug, but these responses tend to often cause the cancer to completely go away, what's called a complete response. And for those women who did respond, these responses tend to be very long lasting. So highly, highly effective drug in those women who have this DNA mismatch repair deficiency. Now, we've taken this data and we've developed and done other things. So, as I showed you, there's also a large number of women who have endometrial cancer who don't necessarily have one of these DNA mismatch repair defects in their tumor. So this is a study that looked at the immunotherapy, but it also combined the immunotherapy, the Pembrolizumab, with another drug called lenvatinib that works in a different way. And basically what this study found in those women who have cancers that don't necessarily have this abnormality, this mismatch repair abnormality, this is a strategy that allows immunotherapy to be fairly effective in these women who it may not have otherwise been so effective with just Pembrolizumab alone. Again, this is a study. This is a study of the combination of lenvatinib and Pembrolizumab. And what you can see here is really impressive response rates and results, again, particularly compared to what we would expect with chemotherapy and other more traditional therapeutics and agents for endometrial cancer. So really, I think this is, these drugs have changed the landscape for endometrial cancer. These drugs, change the way that I talk to patients in my office every day, and have really opened up new treatment options for women with recurrent endometrial cancer. And again, these drugs, these combinations, you'll see, 2017, 2019, all of this is really over the last 5 years, where we're able to incorporate these treatment strategies, these drugs in our armamentarium against endometrial cancer. So again, I think really, as physicians, really, that the options that we have now are vastly different than what they were even 5 years ago. So really, I think, bringing new hope to patients who do have recurrent endometrial cancer. So with that, I want to make sure there's plenty of time. Jacqueline will be speaking, and plenty of time for questions as well. But I want to conclude. I hope what I've shown you today is, number one, one, that overall endometrial cancer has a very, very favorable prognosis. And because of that, it's really key why we need to raise awareness about the early signs and symptoms of endometrial cancer so we can detect and diagnose this cancer early where it's highly treatable. Number two, the treatment for most women with endometrial cancer generally involves surgery, and the surgeries that we have are better now. Number three, there are now better adjuvant therapies. So after surgery, so hopefully decreasing the risk of the cancer will come back. And then number four, I think the latest advance is the new drugs, the new treatments, the new strategies that we have. It's really a sea change in the way that we can approach endometrial cancer. So really our understanding, I think, has been directly translated into being able to cure a greater number of women with endometrial cancer. So with that, I will end. And again, I thank everyone very much for all your attention today. Thank you.
Thank you, Dr. Wright. And at this time, we're going to hear what it is like being diagnosed with endometrial cancer from a patient's perspective. And I'd like to introduce everyone to Jacqueline. Jacqueline Mbayo is the Director of Research Partnership at the Endometrial Cancer Action Network for African Americans, also known as ECANA. She has a background in health information management and has worked in clinical research for over 10 years on several phase 3 clinical trials. After her own diagnosis in 2017, Jacqueline has a life mission to educate, empower, and build community with Black women diagnosed with endometrial cancer and promote meaningful patient-centered research to improve health outcomes. And now I would like to turn it over to you, Jacqueline.
Thank you, Nefertari. Thank you for inviting me to share my story here at the SHARE webinar. I really appreciate the SHARE organization. And Dr. Wright, thank you so much for that very informative presentation. I really loved your slides. So my name is Jacqueline Mbayo, and I was diagnosed with endometrial cancer in November of 2017. I experienced postmenopausal bleeding, and I was very concerned because I knew that I should not be bleeding. I had been postmenopausal for several years, but what I did not know was that postmenopausal bleeding could be associated with cancer. So I was a little put off that I had even begun bleeding again. And that's what prompted me to call my gynecologist, and I got an appointment right away. My gynecologist performed an in-office biopsy, and she told me that I would probably need a D&C as well in order to know what was going on. The in-office biopsy came back benign, and so I had the D&C soon after. A few weeks after the D&C, my gynecologist called me. It was very unusual for her to call me personally, so I knew there was a problem. And that's when I got the news of the endometrial cancer diagnosis. I had never heard of endometrial cancer before, and I was very surprised to have a cancer diagnosis at all. My gynecologist informed me that I needed to have a hysterectomy within the next 2 weeks. And as she was speaking to me, my mind started racing, and I felt like I was having an out-of-body experience. My gynecologist scheduled me to see a gynecologic oncologist, and I was in his office 7:30 the next morning. That's how fast things were moving. The gynecologic oncologist examined me, and he told me that he would be performing a robotic hysterectomy, and that we would know more about my treatment plan once I was staged. When I learned what my stage was, I knew that I was in for the fight of my life. I was stage 3C1, grade 3 serous. By this time, I had been referred to my medical oncologist. It was now December 2017. And because I had an aggressive cancer, the serous, I was informed that my treatment would also be aggressive. My treatment was sandwiched. I had 3 rounds of carbotaxol chemotherapy, 25 rounds of an external beam radiation, and 3 rounds of an external vaginal cuff boost. That was in lieu of the brachytherapy. The external vaginal cuff boost is an external high beam radiation that's targeted to the vaginal cuff. And when there's a recurrence, that is often where the cancer occurs, at the vaginal cuff. After I completed my radiation, I had 3 rounds, another 3 rounds of chemo. I had chemo every Thursday. And for me, 3 chemo infusions equaled 1 round. So altogether, I had 18 chemo infusions in total. It was grueling. Treatment was really, really hard. But I did it. And I feel stronger now than I did before. Early in my treatment, I remember wishing that I was back to work and doing all the activities that I loved. I wanted to get back to normal, but I realized that I might never get back to work. At that time, I was still surprised by my cancer diagnosis, but I realized that God was not surprised. And I believed that He had a plan for me. As a Christian, I put my faith in Jesus Christ, and I believed that I needed to embrace the plan that God had for me. I began to understand that this was my new normal. I started to think about what I could do to get well and stay well. And so after talking to my care team, I came up with a self-care plan for myself: eating well, sleeping well, praying, exercising, and drinking lots of water. That was my 5-point plan. I also started advocating for myself. I began communicating more with my care team. I started telling them more about the chemo side effects that I was experiencing. You know, the fatigue, the indigestion, the difficulty swallowing, the metallic tasting food, the neuropathy, the chemo brain. I was cognitively impaired during most of my treatment due to the chemo brain. I also experienced urinary incontinence and muscle weakness to the point that I had difficulty walking. And because I had mentioned all of these side effects to my care team, they were able to help me to manage the side effects. I had a fantastic care team. I realized just how awesome they were when I started hearing some of the stories of other women diagnosed with endometrial cancer. I also had the best caregiver ever, my husband, who took off from work every Thursday to accompany me to my chemo treatments. I'm very blessed. What also helps me on my journey is that I attend the SHARE uterine cancer support groups, both the large group that meets on Monday, as well as the group for women of African descent. That group meets once a month on a Wednesday. I also attend the ICANA Survivor Sanctuary. ICANA is the Endometrial Cancer Action Network for African Americans. The Survivor Sanctuary is a safe space for chair yoga and a conversation. And we meet twice a month on a Friday. The women at the Survivor Sanctuary are awesome. They are the endometrial cancer survivors that support me daily. And it's because of them and the women in the SHARE support groups, I believe they are the reason, of the big part of why I'm doing so well mentally, emotionally, spiritually, and physically. And not only am I being cared for in the support groups, I also have an opportunity to care for others. I love supporting women newly diagnosed or in treatment, or even those who have completed treatment. That gives me the greatest joy and pleasure to help someone else on this journey. because no one should have to walk this cancer journey alone. It's not easy. So if you're able to join a support group, I highly recommend it. I completed my treatment in July of 2018. I was still battling with the chemo brain, the muscle weakness, and the fatigue. I felt like I needed to get out of sick mode and into wellness. I needed to flip the switch. So I took a 1-week vacation to Cancun. I was sick and I was weak, but it felt good to be in the Caribbean waters. And when I got back home, I felt refreshed. That was a big turning point on my journey. I was now in wellness mode. I continued my self-care plan, and I started feeling better and better every day. Eventually, I had physical therapy to help with the muscle weakness, and I also saw a dietitian. So for my surveillance, I saw my gynecologic oncologist once a year, and I saw my gynecologist once a year. So every 6 months, one of them was always examining me. However, this past February, my gynecologic oncologist told me, "Congratulations, Jacqueline, you don't need me anymore." I am so grateful for everything that my gynecologic oncologist did for me. I am so grateful. I used to have, I still see my medical oncologist. I used to have visits every 3 months, but since 2021, I now see my medical oncologist every 6 months. And I thank God every single day that I am NED, no evidence of disease. Today, I work with ICANA. ICANA educates, empowers, and supports the community of Black women diagnosed with endometrial cancer. As the Director of Research Partnerships at ICANA, I have the wonderful opportunity to work with endometrial cancer researchers that are conducting patient-centered outcomes research that addresses the significant racial disparities for Black women diagnosed with endometrial cancer. The disparities are alarming. For example, and Dr. Wright spoke to this, I'll just give you a statistic here. Endometrial cancer is reported to be 31% lower among Black patients compared to white women. However, the age-adjusted mortality among Black women is approximately 84% higher. In other words, Black women are dying 2 times more than white women with endometrial cancer. I want to change that narrative. I want to change that narrative. The sole purpose for everything we do at ICANA is so that Black women will have better health outcomes. And this is what I know. When Black women have better health outcomes with endometrial cancer, all women will have better outcomes. So this is my life mission. This is my new normal. And this is the work that God had planned for me. Before I close, I would like to encourage everyone here. If you received an endometrial cancer diagnosis, if you've had a hysterectomy, if you've had chemo or radiation, know that you are very strong and courageous. Treatment is not easy, but if you are in treatment, do everything you can to complete your treatment. Fight for your life. Fight for your life, because you can have a very good life after a cancer diagnosis. So wherever you are in this journey, know that you are a warrior, a conqueror, a champion and a winner. We're all winners. So as we're winning, let's help raise awareness about endometrial cancer so that someone else can win. Thank you.
Thank you, Jacqueline, for that. Very beautiful and emotional at the same time. I want to thank you. Yeah. Very well said. Lots of information.
Thank you, Nefertiti.
At this time, I'd like to introduce the Q&A. You can ask questions of either Dr. Wright or Jacqueline, or both. You can still submit your questions in the Q&A section at the bottom of your screen. We were trying to get through all of the questions submitted, but we may not be able to due to time constraints. So the first question is for Dr. Wright. Have there been any research studies that link environmental factors to uterine cancer occurrence?
Yeah, thank you so much for the question, Jacqueline. Thank you so much for sharing your story. I mean, this is what we need to get out there to women to recognize their symptoms and women who are going through this journey. So thank you. As far as environmental factors, there's been certainly less done on uterine cancer than some other cancers, things like lung cancer, where there's very strong association between smoking and cancer incidence. There are some of the rare cancers have been associated with asbestos and radiation to other areas of the body, but they tend to be fairly weak associations, especially compared to some of the genetic syndromes, as well as obesity and estrogen stimulation. So I would say, at least based on our knowledge now, environmental factors probably play a relatively small role in the incidence and development of uterine cancers.
Thank you for that answer, Dr. Wright. So this next question is, surrounded, these next three questions, in fact, are surrounding recurrence. And I think you covered a lot about recurrence and the various treatments that are available. So with that being said, this person is asking, what symptoms should a patient look out for that might indicate a recurrence, and what tests would diagnose a recurrence?
Yeah, so when you look at recurrence overall, the most common place for uterine cancer to recur is in the vagina, so where the uterus used to be. So if you have a recurrence in this area, you'll often experience vaginal bleeding, sometimes pelvic pain. So if you do experience those symptoms, you should get in and be evaluated by your doctor. Typically, patients after they're diagnosed with endometrial cancer and are treated undergo periodic pelvic examinations, usually every 3 to 6 months. And these examinations are specifically targeted to detecting abnormalities inside the vagina. And the second most common area that the cancer can come back is it can come back in the abdominal cavity. And if that happens, people will typically experience gastrointestinal type symptoms. So nausea, vomiting, bloating, abdominal pain, sometimes change in your appetite. So if you do experience those symptoms, again, it's really important that you let your doctor know. You get into your doctor's office. Oftentimes you'll be evaluated with imaging, a CAT scan, a PET scan, some type of imaging modality to look at the abdominal cavity.
Thank you for that information. And the third part to that question, which I know you went over during, your presentations and in the slides, are there any new treatments for patients who have recurrence? Would you like to elaborate a little bit on that?
Are there new treatments for recurrence? Yeah, I mean, I think now there are lots of new treatments for recurrence. Probably, whether there's the most excitement about is immunotherapy, where there are now 3 drugs that are approved in this space by the FDA, which is all new in the last 5 years. So I think there's a lot of excitement, and endometrial cancer really often responds very well to immunotherapy. So that's important. And then there are a number of different targeted therapies that I shared a little bit about that, particularly Herceptin, now for women who have serous carcinomas, is something that's fairly routinely used in clinical practice at this point. But other drugs like Letrozole, everolimus, there are many new drugs that are coming out for uterine cancer now. So again, I think in the last 5 years has really seen a big shift in the way that we approach this.
Thank you. So this next person is asking, what does a positive cytology mean when diagnosed with uterine cancer?
So so I assume probably what the question is directed to. Typically, when we do surgery, before we start and remove the uterus, we put some fluid inside the abdomen, and then we remove that fluid. And sometimes there can be cancer cells in that fluid. So if we detect those cancer cells in the fluid, what will happen is your doctor will kind of put that in context of all of the other factors as far as, where the cancer is, if the cancer spread deeply into the uterus, if it's spread to the lymph nodes, to help formulate a treatment plan after surgery. So probably if you, in most scenarios, if you have a positive cytology, your doctor is probably going to be a little bit more likely to recommend some additional treatment, either chemotherapy, radiation, or the combination of chemotherapy and radiation. But this is one of those scenarios where it's really, highly individualized. So that definitely warrants, a good discussion with your doctor on the pros and cons of different treatments.
This next question is a subject that comes up a lot, within the support groups, and it is about the CA-125. And this person is asking, is the CA-125 the best way to monitor someone after treatment is completed and in remission?
So the CA-125 is a blood test that can detect a specific protein. It's most commonly used for patients with ovarian cancer, to monitor for ovarian cancer. Having said that, there are some endometrial cancers, especially some of the type 2 endometrial cancers that produce CA-125. So in some women with endometrial cancer, the CA-125 can be used as a test for monitoring after treatment, and it will sometimes go up. Now, there are, probably a lot of other of the type 1 endometrial cancers that really aren't associated with CA-125. So I think that that this is really, depends on the specific type of endometrial cancer. If your doctor found that this was elevated before you started treatment, which would suggest it is a marker for your particular cancer, then your doctor is probably going to be more likely to monitor that after you've completed treatment. So again, I think this is one of those scenarios. There's not really a right or wrong answer, but this is something you should definitely, talk to your doctor about on why you do or don't want to necessarily do the test.
Thank you. So this next question is, this person is asking, is the thickening at the vaginal cuff after surgery common, and should it be monitored, and how?
Well, the vaginal, yes, so there typically is, so the vaginal cuff is the area where the cervix and the uterus used to be after surgery. So there typically, is some thickening of the vaginal cuff after surgery. Usually, it does get better over time, and that thickening decreases. Why your doctor will monitor the vaginal cuff is because of all the places, the vaginal cuff is the area that's for cancer most likely to recur. So when you go for follow-up visits, you'll probably get, pelvic examinations and speculum examinations. That's to examine this area, the vaginal cuff. And that's why I think to the prior question, if you're having, symptoms of, new vaginal bleeding, pain, something that's different from you, should definitely bring that to your doctor's attention, because this is, an area that needs to be monitored pretty closely. And, we want to hear about those symptoms as soon as you're experiencing them.
Thank you. So this next question is for Jacqueline, and this person asks, what's the name of the support program for Black women?
support, well, there's two groups that I attend. One is the SHARE for women of African descent. And then the other group that I attend is the ICANA Survivors Sanctuary. And I can give the website. It's icanawomen.org.
Thank you for that. There's another question for you, Jacqueline. You mentioned that you had chemo brain during your treatment. Can you tell us a little bit more about what you experienced and what that was like for you?
Sure. Well, sometimes chemo brain is called chemo fog. And so I felt like I was in a mental fog. I could not think clearly. I had difficulty concentrating. I was having difficulty finding the right word. I was having trouble following a conversation or even remembering a conversation. I had a very short attention span. And I often felt very confused. It was very debilitating. I just felt like throughout my treatment, I was like in a mental fog.
Thank you for answering that. And this next question is also for you, Jacqueline. And this person would like to know, how was the communication between you and your care team? And did you find that your questions and concerns were addressed during your visit?
Communication, thank you for the question. Communication was awesome with my care team. They treated me like I was a member of their own family. They took time to listen. They did everything that they could to make me feel comfortable, and they supported me. And not only did they support me, they supported my caregiver, which was my husband. They supported both of us. And they answered every single question that I had. I did have chemo brain, so I used to write my questions down. I used to write my questions down in the notes on my iPhone, and they addressed every single question, every single concern that I had. And we functioned as a team, and everyone had the same goal, and that was to get me well and make me as comfortable as possible. So I understand completely how fortunate I am to have such a care team.
Great tip in writing down those questions for your appointment. And it sounds like you had, some really great communication between yourself and your care team. That's good to hear. So this next question, and it may possibly be our last question. This next question is for Dr. Wright. Is there a recommended nutrition protocol for prevention and or reversal of endometrial cancer?
That's a tough question. I mean, there are probably, lots of dietary influences and factors that may be associated with uterine cancer that we don't understand. As I shared in the slide, but by far and away, the strongest risk factor for endometrial cancer is obesity. So kind of a healthy diet, exercise, if women are overweight, weight loss, there have been studies that have shown that weight loss, it reduces the risk of endometrial cancer. From a pure, scientific standpoint, that's probably the best advice that I could give. But again, there are probably, other, dietary factors and influences that, we just don't understand yet. But per se, it's hard to recommend or say, if you have followed some type of specific diet, or nutrition that it'll decrease your risk of endometrial cancer.
Thank you for that answer. I think we may be able to fit one last question in, and it's also for Dr. Wright. This person says that they, if you were diagnosed with stage 1 and didn't have treatment other than having a hysterectomy, how frequent should you have follow-up appointments?
It's a good question. I mean, there are, stage 1 endometrial cancer is the most common stage of endometrial cancer. Having said that, there are lots of different variations based on what specific type of tumor, the grade of the tumor. So it really, probably depends on your risk of recurrence. There's not a right or wrong protocol for follow-up. Typically, we'll do follow-up every, 3 to 4 months or so for the first couple of years, and then every 6 months or so after that. So that, over time, the vast majority of recurrences will recur within the first 2 years after your diagnosis. So that 2-year mark is often a big milestone where the risk of recurrence starts to go down, and we typically will space out the follow-up visits. But again, this is probably one of those questions where, it's individualized. It warrants a discussion with your doctor. You've got to take in the actual risk that the cancer will recur based on all the circumstances I described.
Thank you. So now, we've come to the end of our program, and I want to thank Dr. Wright and Jacqueline for an informative program. And thanks to all of you for participating and submitting your questions. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. Please check out SHARE's other educational programs and support groups on our website, as well as volunteer opportunities. This concludes the webinar. Thank you, everyone. Bye-bye.